So we really wanted to walk through, review a little bit about ASD, look at the different service delivery systems, how they overlap, how they are distinct and separate, define the behavioral health services really according to our new legislation, well, it's not so new now, SB 946, talk about some of the research-based practices, talk about the difference between comprehensive and targeted behavioral treatments, and really then review this whole referral process, at least ideally how it's supposed to work. So very briefly, we just wanted to go over autism spectrum disorder. What is it? We have a new classification diagnostic. The DSM has been revised. We have a new category of neurodevelopmental disorders, which we did not have in the previous version of the DSM. And autism spectrum disorder fits in that category of disorders. We've gone from 3 domains that we use in terms of diagnostic criteria to 2 primary domains. Social communication and social interactions is one, and then the second one now is restrictive and repetitive patterns of behavior, interests, or activities. So there's some collapsing and some distinctions in terms of our diagnostic categories, but it's still the same disorder. What's somewhat different, however, is instead of taking the spectrum and chopping it up into pieces and calling it, this is autistic disorder, this is Asperger's, this is PDD-NOS, and sort of implicitly, I think, using those differential diagnoses along the spectrum as a way of sometimes implying severity, we actually now in the DSM-5 have severity levels. And so these are based on the supports needed to really be successful and be included in community activities and in daily life. So level 1, they all require support. So it's not that if you have a level 1 severity that it's so mild that you really don't probably need services. And I think sometimes we've had this struggle in terms of if you're diagnosed with PDD, you may not get any services from the regional center, but if you have autistic disorder, you will get services. And again, we're going to try and talk about what's different in terms of regional center eligibility with this new diagnostic criteria and these new severity levels, and how do we use them and think about them now clinically, and how does that help us in terms of figuring out these different service delivery systems for treatment. So just a quick update for those of you who may not have seen the most recent prevalence data that's coming out of the CDC and the Ed.M network. That is a surveillance program that the CDC has run for many years in a variety of communities, 11 different communities across the United States. We have gone from the most recent published data prior to this was 1 in 88. This one is published in this year, 1 in 68. It's a lot of variability across the different states. You can see there are some little tiny states up here in the east who are part of it, sort of a row of states here in the southeast, a few in the Midwest, and then 3 states in the west, or at least west of the Mississippi. I think these probably are west of the Mississippi too, and then Wisconsin up here. And the method that the Ed.M network is using is they're really looking at records, and they're looking at school records, medical records, to try and find diagnostic criteria, children who meet diagnostic criteria. So they're not evaluating children in each of these states. And they're looking at children who are 8 years of age. So it's a different methodology than a lot of other prevalence studies. But they've been using the same methodology probably over 10 years now, and probably, well, let's see, maybe 15 years. So the methods are the same. So again, the prevalence does seem to be continuing to increase. So one of the things that has happened, at least in California, is that a diagnosis now for services requires medical diagnosis of autism spectrum disorder by someone who's licensed in the state to either practice medicine or is a mental health professional. So as defined by the legislation, that includes pediatricians, developmental pediatricians, neurologists, psychiatrists, also licensed psychologists, including licensed educational psychologists. So these are just examples of who are considered licensed professionals who can make this diagnosis. Clearly, there's a broad range of diagnostic experience and training. So oftentimes, some primary care physicians feel very comfortable making this diagnosis. Some primary care physicians would prefer to refer to have a diagnosis made by a subspecialist. But I think it's really, in terms of your private health care and insurance, a medical diagnosis is required. It may or may not be required for a regional center. I'm going to ask Robin to sort of talk a little bit more about that. And it's not a requirement for necessarily to have services provided through the educational system. We hope that it would be taken into consideration. But there's really a difference between the healthcare system in terms of insurance covering behavioral health services and eligibility for services in special education. So the Individuals with Disability Education Act and the Education Code have specific criteria, but they're different from the DSM-5 or the DSM-4 that we use in terms of making a medical diagnosis. And so it's important to understand, both as a physician who's referring, or a psychologist, or really as a parent too, that sometimes there can be discrepancies between these different systems and their different eligibility criteria and diagnoses. So if you are determined through the education system to be eligible to be receiving services under a diagnosis of autism, that does then ensure the right for free and appropriate public education in the least restrictive environment. We can talk a little bit about that in the discussion. So it's not required that you have a medical diagnosis of autism, but you need to have characteristics of autism that impair your ability to learn and to be a part of the general education classroom requiring supports. So this is just a graph of the number of children in the United States who are served with this category, autism category, in special education over the years for several decades, and you can see clearly, just as the prevalence data would suggest, it's increasing. In terms of the CDC, it's also increasing in terms of the number of children served in special education. And right now, the latest data from 2012, looking in California, how many children are being served with a diagnosis of autism. You can see this is across the age, and this is in 2012. So most of the kids being served fall into this age range, so from 3 to 17. And if you were 17 in 2012, you were born in 1995, and just to go back to this, you can see it just sort of mirrors this. This is, this slope just reflects this same slope.
So in terms of eligibility for regional center services, we are typically looking at a medical diagnosis, but we're also interested in measurement of adaptive functioning. Diagnoses that make you eligible for regional center services include cerebral palsy, epilepsy, autism, intellectual disability, and then we have what we call the fifth category, which is other conditions related to intellectual disability that require similar treatment and supports. So the reason that we're also interested in looking at adaptive functioning is that we're also looking for this substantial disability. And as part of Lanterman, the disability or the diagnosed condition also needs to result in major impairment of cognitive and or social functioning. and have limitations in 3 or more of those areas that you see there. So communication, which is both expressive and receptive language, learning, self-care, mobility, self-direction, capacity for independent living, and economic self-sufficiency. So you can see that these are considerably different than what education code looks at and what regional centers look at as far as requiring a diagnosis for an eligible condition. So the overlap in care, and this is kind of a busy slide, but we have special education in the yellow over there, which includes IDEA. There are 13 qualifying categories under special education. The services come with the offer of the free and appropriate public education and are part of an IEP program. This is sort of mirrored over on the regional center side, where you have Lanterman and Title 17, which are the guiding legal codes for regional center services. We have 5 qualifying categories, and our services are driven by IFSP and IPP. So IFSP is an individualized family service plan, and that's part of the Birth to 3 program. And then the IPP, or individual program plan, is part of the 3 to lifespan services offered under Lanterman. And there's always been considerable overlap between special education and regional centers. So we're both focused on looking at providing services in the least restrictive environment. There have been partnerships or memorandums of understanding that have been created that have helped kind of link our funding and our programming, especially for our younger children, together with shared funding. We're both responsible for transition planning, both into school and then out of school, as a person ages out of that system. And we're looking at complementary support, so where education may be focused on more of the education curriculum and ed code responsible teaching, then we're looking at supplementing that at home with home-based living and community-based living. So then last 2 years ago, we got the medical system that comes into play with SB 946, and that has kind of been an interesting transition because now we have another main player at the table as far as trying to provide services and coordinate care. So the medical system is looking at what is medically necessary. So what is medically necessary, what is related to a free and appropriate public education, and what meets the needs of somebody who has at least one of those 3 of 7 substantially disabling conditions. You know, there's kind of a juggle that happens with that, and they don't line up as neatly necessarily as we could have wished for, maybe. So the overlap between regional center and medical system is that regional centers have been able to pay co-pays for autism services. We've been able to support families with that. And we're both looking at a medical diagnosis, so DSM-5 diagnosis for autism. With the education and medical system overlapping with each other, I think this is still something that's being teased out a little bit. And there is a shared responsibility for management of intervention for children with autism spectrum disorders between those 2 systems, but how exactly they work together and how exactly they overlap with each other is still, I think it's a moving target at this point. Oh, and then we also have the different mandates for how the systems are supposed to interact with each other. So the medical system does not replace what special education is responsible for, and then regional centers are mandated to use what's called generic resources, or resources that are out there that are legally mandated to provide services. So we would not be able to supplant what the medical system is responsible for paying for, or what the education system is responsible for paying for. So that's where we get into kind of complementing or supporting the intervention, but not supplanting it. So SB 946, in a nutshell, says that behavioral health treatment is defined as professional services and treatment programs, including applied behavior analysis and evidence-based behavior intervention programs. And the treatment, it must be prescribed by a licensed physician, and then it's provided by what's called a qualified autism service provider, who can supervise either a qualified autism service professional or a qualified autism service paraprofessional. So we will get into what that looks like a little bit later with what the service delivery models actually look like. The important thing to note here is that we are looking at evidence-based practices, though. And just a brief overview of applied behavior analysis. This is the strategic application of scientific principles of human behavior and learning. And using a scientific method or an ABC format, the idea is to be able to predict and influence the occurrence of behaviors, either behaviors that you want to increase if you're looking at skill building, behaviors you want to decrease if you're looking at behavior management strategies. So we want to obviously teach or increase desired behaviors. We want to reduce or eliminate those that are maladaptive or undesired. And within applied behavior analysis, this really is an umbrella term for a theoretical approach. I think a lot of people equate applied behavior analysis directly with discrete trial training or with the Lovaas model. And those are one type of strategy under applied behavior analysis, but it's not the only one. So ABA is the umbrella framework for very specific strategies that fall underneath it, that fall within this theoretical approach. So what are evidence-based practices? Those of you who went to the fabulous presentation by Ann England this morning some of this might be a little deja vu for you, but I think it is very interesting to look at, that was applying evidence-based practices to the education system and to Common Core standards. This is looking at the medical side of things, and that we're still talking about evidence-based practices. And if this is familiar, then that's great, because we're still talking about the same practices that can be applied in both settings. So EBPs are interventions and practices that have empirically demonstrated effectiveness. So science has shown that these are effective intervention strategies. And the evidence-based practices are typically identified through a process called meta-analysis, which looks at a broad range of research that's been done over the years. It creates very specific criteria or thresholds for what is considered a high-quality research study, and those that meet that criteria would then be considered evidence-based practices. And the core intervention components that have been shown to be desirable or evidence-based can be used singularly or in combination with each other. And we'll get into that with the targeted and comprehensive interventions in a minute. Why do we use EBPs? Well, research supports them, and we typically want to follow what research supports. You have a higher probability of having a successful outcome if you use practices that have already been proven to be effective. It's not a guarantee, but it definitely increases your probability of having the outcome that you're looking for. It is considered best practice. It helps you make informed clinical decisions, and it's the standard of practice in most major professions in this field. So medical, psychology, education, allied health hold evidence-based practices to be valuable and, the intervention of choice when at all possible. And it's the law. So Education Code, Lanterman Act, SB 946 all indicate that you have to use evidence-based practices. So we have two key projects. These are nationally vetted authorities on evidence-based practices. We have the National Professional Development Center for Autism, and then we also have the National Standards Project. Is this familiar to anybody? Yes, good. The National Autism Center identified 11 established treatments, and you can see them listed there. We have antecedent package, behavioral package, comprehensive behavior treatment for young children is part of the next section that we'll be talking about. And their guidance around choosing evidence-based practices was really to start with the established interventions and choose interventions off of this list of 11 based on clinical judgment, consideration of the family, consideration of the individual client that you're trying to treat, and start here because these have been proven to be effective. We also have 22 emerging treatments that were identified by the National Autism Center, and you'll see in a moment some of these actually have become considered fully evidence-based at this point. Cognitive behavior intervention will be one of those. So even in the last 4 to 5 years since this list was published and the most recent list was published, we've had updates in research that have made emerging treatments become considered established or evidence-based practices. There's more on the 22. And so moving on to the National Professional Development Center on Autism Spectrum Disorders, they have a very recent publication just this March. There was a publication on 27 evidence-based practices, and this was actually an update from a 2008 publication that had 24. So again, we're increasing our interventions, we're increasing our research that proves that these interventions are effective. And you'll see here, cognitive behavior intervention did switch over and is now considered an evidence-based practice for autism treatment. And there's the overlap between the two. So across the blue column down the right-hand side there are the evidence-based practices that were identified by the National Professional Development Center, and then the pink across the top is the National Standards Project. And the reason for the difference between the two is that they did take kind of different strategies in grouping their approaches or their EBPs together. So the National Standards Project tend to kind of package things together. So you can see in that first column, there's the antecedent package, would be one evidence-based practice from the National Standards Project, but it is comprised of 3 prompting, antecedent-based intervention, and time delay evidence-based practices under the NPDC. So people get a little confused of, oh, should I use this one, should I use that one? If you choose from that list of 11 and that list of 27, you're good to go. Those are the evidence-based practices. If there's overlap in the definition between the two, that's totally okay. Just slightly different ways of looking at how to design intervention. Where can you find these resources, you ask? On the CAPTAIN website. This is the California Autism Professional Training and Information Network. So exciting that we have this in our state. This is a single place that you can go to access information, latest and greatest updates on evidence-based practices. So down that column on the left-hand side, there's a link for the National Professional Development Center on Autism, a link for the National Autism Center. There's some resources that are included in there, and that's for the 2 summits that this group holds every year. And then there are also links to the Autism Internet modules and the ADEPT parent training, Autism Distance Education parent training, that all of these are free resources. You can use them to your heart's content. You can share them with families. The ADEPT modules are actually very family-friendly and very easy to use and pretty quick to go through. So those are the resources that are out there for you.
All right, so when we look at behavioral health treatment under the framework of applied behavior analysis being sort of the broad theoretical framework, and we get down really to the implementation level, it's important that we break it apart into really how the service is delivered and how it's packaged. And there are 2 different basic categories of treatment that fall under this behavioral health kind of treatment paradigm. The first one is comprehensive behavior treatments for young children. And other names for this are intensive early intervention, early intensive behavioral treatment. The other realm of behavioral health treatment has to do with targeted behavioral interventions. And this is different in that in this form of treatment, in this approach, you're really looking at a specific behavior, usually a behavior problem or a behavior excess, that's interfering with the person's ability to function and to access the community and natural environments. And targeting that particular behavior, assessing its function or purpose, and developing a treatment plan specific to that behavior, rather than a comprehensive approach where you're addressing a multitude of different behaviors and skills early on to try to really ameliorate some of the symptoms of autism. So let me talk first a little bit more about comprehensive behavioral treatments for young children. This is an intensive service delivery model, usually 25 to 40 hours a week of therapy. And it's been identified as effective for children up to the age of 9. Now, certainly that doesn't imply that you start the intervention at 9. Ideally, this intervention is started as early as possible from the time of diagnosis or identification. And during that treatment period, it's evolving as the child's skills evolve. The intensity of the treatment is varying depending on the needs of the child, and you're working into more naturalistic contexts and environments over the course of treatment. Measurement to assess the effectiveness of the program takes place constantly. Data on skill acquisition, data on progress towards targets, movement through a curriculum that has a specific scope and sequence of skills. Services usually provided in a variety of different settings with rich child-to-therapist ratios. And we're going to show you some videos just so you get a picture of what this looks like. But oftentimes, initially, the therapy is provided one-on-one, one therapist, one child, working on skill acquisition until the child is really able to access learning in environments that involve more children, more distraction, more variability. The duration of this type of treatment usually lasts between 2 to 4 years. The targets are the defining symptoms of autism. So really, you're addressing communication, social interaction, play, a lot of the joint attention and imitation skills that often young children with autism are not automatically demonstrating. And then, of course, behavior excesses or behavior challenges that are presenting. And one of the features of comprehensive behavioral treatments for young children is that you really aren't just pulling skills out of the air. You're following a really comprehensive scope and sequence of developmental skills and moving as quickly as you can through those skills to help the child, in essence, kind of catch up with their typically developing peers. Who provides this type of treatment? Robin mentioned earlier that SB 946, the law, defines who's able to provide comprehensive behavioral treatments for young children. And it's a layered type of a system, which is a little bit unusual. Normally in the medical field, you make a referral to the specialist, and the specialist is the one providing the service. In comprehensive behavioral treatments, the qualified autism service provider is sort of that top layer. That's the licensed or certificated person who then supervises a qualified autism service professional who then provides direct supervision of a qualified autism service paraprofessional. You might hear that bottom person, that's the one doing most of the therapeutic interaction with the child, referred to as a tutor, a paraprofessional, a behavioral technician. But they are the ones doing the majority of the therapeutic interaction with the child. SB 946 does define what these individuals, what their qualifications are. So a qualified autism service professional, that's that top layer. Typically a board-certified behavior analyst, a BCBA, or someone licensed in California in a mental health field or a medical field is that qualified autism service provider. And we've listed some examples there, but much like is the case with a diagnosis and being able to render a diagnosis, simply holding the appropriate license doesn't necessarily give someone the clinical expertise to fill this role. So really, the qualifications, the licensure, the certification is described here, but we're really looking for people who have significant experience and understanding of comprehensive behavioral treatment and what is involved in delivering this kind of service. Qualified autism service professional, that's the next level down. This person or people are employed and supervised by the qualified autism service provider. They provide treatment according to the treatment plan that is developed by the qualified autism service professional. They're an approved vendor of the regional center, and they have training and experience in providing services to ASD pursuant to whatever state they're in, so pursuant to how it's outlined in our state in SB 946. And just in terms of describing how this might look, this person is probably going to have regular contact with the child receiving the service, regular contact with the autism paraprofessional, and usually for every 10 hours of direct therapy that a child is receiving, there's going to be about 2 to 4 hours of contact and supervision by this person. Okay, so there's a ratio that tends to exist between frequency of observation by this person and the number of hours of therapy that the child is getting. And then, of course, we have the Qualified Autism Service Paraprofessional, AKA the tutor, the person who's providing the 25 to 40 hours per week. These are unlicensed, uncertified individuals who are employed and supervised by the Qualified Autism Service provider. They provide treatment and implement the services in accordance with the treatment plan and what the plan says. They meet the criteria set forth in our law, and they are supposed to have adequate education, training, and experience as certified by the Qualified Autism Service provider. So the provider actually sets up the training program, process, and protocol for the paraeducators, and it looks different depending on that provider. The number of hours of training, the number of hours of supervised support can look very different depending on the provider. So where does this comprehensive behavioral treatment for young children typically take place? As I mentioned before, the context typically starts in a highly structured environment. Ideally, children are accessing this service very early on, as soon as possible after diagnosis. And the idea is that they're going to start with a level of intensity and in a controlled enough environment to be able to get really rapid learning and skill acquisition, and really where they can learn to learn. This may be in a home setting, and oftentimes, depending on the age of the child, starts out in a home setting. Can also be in a school or a clinical setting. It progresses, however, and should progress from this one-on-one, more tightly controlled, sort of isolated context into more naturalistic circumstances and settings. Progressing from the home into the community, the child care setting, an educational setting, from one-on-one into more group types of experiences with typically developing peers. Outcomes. Well, a best outcome when we identify early, when we provide intensive enough services with high quality, a best outcome in comprehensive behavioral treatments for young children are that the child would catch up with their peers, that they would benefit, be able to benefit at the end of this from typical instruction in a natural context. In other words, they would be able to enter school, go into the general education setting, and access instruction without ongoing intensive support required. And the research is telling us that many children can achieve this best outcome. The data varies depending on the research that you look at, but a fairly high percentage of kids who receive this are able to really make significant gains, and many are able to accomplish a best outcome. Many, though, will require ongoing support. For example, when they enter school, they may meet the criteria for an autism qualifying disability for special education and require the services of special education in order to access their educational program. They may require speech therapy, occupational therapy, small group or intensive individualized instruction through the IEP. They may be able to benefit from some time in the general education setting with some more structured small group instruction going on as well. But the best outcome is really for that child to be able to catch up with their peers. And of course, this is everyone's hope. The evidence for comprehensive behavioral treatment, you can see that here. And again, the outcomes really range in terms of a best outcome. Some of the studies indicate that 13% or so of kids can accomplish a best outcome. Some of them indicate a much higher percentage. it's probably realistically somewhere in between there. And of course, a lot of it depends on the quality of service. So what does this therapy look like? I have a few different videos I want to show you that give you an idea of what comprehensive behavioral treatment for young children look like. And the main methodology, the main strategy that you're going to see in this particular video is the use of a technique called discrete trial training, which in comprehensive behavioral treatment, because we're really trying to get a rapid learning trajectory, it's intense, and this particular method allows for some really good intense instruction, and it allows us to teach kids pretty quickly some of the skills that are necessary for them to be able to learn in more complex types of environments. So the skill that you're going to see worked on in this particular video segment is imitation. This little guy is learning how to imitate motor movements, and she's using a discrete trial teaching approach with him.
Okay, ready? Do this. Nice job. Do this. Awesome. Do this. Cool. Do this. Nice job, Logan. Do this. Woohoo, you did it. Here you go.
So he's pretty new. He's just learning to learn. He's learning how to sit. He's learning how to attend. He's learning how to watch what she's doing and imitate what he's doing. You can see his attention still pretty flighty, and you can imagine if there was a room full of children or lots of other things going on, it would be pretty difficult to teach him. So the environment is still pretty controlled, pretty quiet. It's one-on-one. It's intensive. They're doing lots of trials to teach him how to imitate or copy what she's doing. Of course, now this program, imitation, would progress. It would get increasingly more difficult, from simple one-step motor movements like you're seeing here to imitation of sequences of motor movements, fine motor movements and gross motor movements, movements that require him to get up out of the chair and move around the room, imitation of play with different objects and use of objects in unconventional ways in play, so that eventually he's able to learn observationally. He can watch someone do something and then proceed to do it, which is how most kids, by the time they enter school, learn. We don't have to teach them every single skill. They observe other kids, they observe the teacher, they imitate or model what they see, and they develop more advanced skills. This is another example of a beginning program. This little guy is learning how to receptively identify and discriminate between common objects.
Touch cup. There you go. Good job. Touch cup. Oh, yay! You did it. Ready? Whoa, bubbles. Cool. Oh, there's a little one, huh? Ooh, bubbles. Pop, pop, pop. Oh, you got it. Whoa, cool. Touch cup. There you go. Good job. Touch cup. Yay! You did it! Whoa. Daniel. Whoa, good looking. Oh, it got on your cheek. You ready? They're right here. Touch cup. There you go. Good job. Touch cup. Ooh, you're so smart. Oh, bubbles. Uh-oh, you're gonna get them? Uh-oh. Good job. Okay, high five. High five. All right, thanks.
All right, again, she was using the discrete trial method, but there were a lot of other evidence-based practices being used in combination with that particular approach. She was using prompting and a system of fading her prompts to get him more independent with the response of just reaching out and touching the item that she was requesting. She was using reinforcement. The bubbles were serving as a positive reinforcer for his effort and attempts. And she was beginning to teach him to discriminate between the different items in the field so that, you know, at some point he'd be able to scan an entire field of probably 5 items and identify the one that matched the label that she was repeating. Of course, this lesson progresses, just like the imitation lesson, from simple objects to attributes and actions and all of the different vocabulary components that we would want to see developed. I have a couple of videos showing you some intermediate programs. And this, again, is where the kids really have learned to learn. They've got some of those basic skills of imitation, receptive language, expressive language. And now we're really working on concept development and broadening their concept, getting away from such a structured context of one-on-one at a table under really tight instructional conditions. So you're going to see an example here of a young man taking a categories lesson and moving it into a more complex type of a format. I'll let you watch and then I'll explain.
Which one doesn't belong?
That's what we just see here. This is. And this is a toy.
Good job! Yeah, you're right. These are dishes, and this is a toy. You're so smart. Hey, Luke, which one doesn't belong?
This one is. These are food. This is clothes.
That's right.
What's that?
That's a seed. I think that's a peach.
What's that chocolate seed?
A chocolate seed?
Why
It
does
kind
it-
of looks like a chocolate seed, doesn't it?
What?
Okay, my turn. Which one doesn't belong?
What's this? This one. These are clothes, and this is a car.
That's right. Way to go.
So still a discrete trial format that she's using, but she's now in the play area. She's using some novel items that he might encounter in the play area at school, or in the play area at home, or in the play area at daycare, and working with him to be able to describe and define how are they basically the same and how are they different, which one belongs to this category and which one doesn't. But you can see also some expanding language going on there. He's able to ask now, what's that? So he's inquiring now. Not every label has to be taught anymore. Now he's got the skills and ability to ask the things that he doesn't know, which is a really important skill for moving into a school setting. And then here's one other example of an intermediate program. These are 2 young men on the autism spectrum, and they're working on lots of different skills in the context of play. And it's being facilitated by the Qualified Autism Service Paraprofessional, and in this case also the Qualified Autism Service Professional. So you see 2 staff supporting them.
These are virtual pieces for you. Ask him nicely. My turn. Oh. Uh-oh. The wheel. Hey, I put the wheel. You can have it. You can have it.
Nice sharing, Alexander.
Thank you, Alexander.
Thank you, Alexander. You're welcome. Hey, put it in. Put the wheel there. Hey, remember to put those on in the hole.
Get there?
Yeah.
Ask him.
My.
Okay, help me, please.
Help me, please. Nice asking duck. May I have to remove this? Like how? You can remove this so you can put the wheel on.
Ask him, how do you do it?
How do you do it?
Alexander, Jack wants to know how you do it.
We put those in the holes.
We put them in the holes, and then it's attached.
Can I put it there? supposed to put it there. No.
Tell him, Jack.
Mom. No, put it on there.
Don't.
The wheel starts to spin. Really, so hard. The tower is gonna fall.
Okay, maybe you and Jack can make another tower for the other wheels.
You can make another tower for the other wheels.
I'll help.
Okay.
Get some pieces.
What? So how are we doing?
So you could imagine how this would look if the therapists weren't there, providing the prompting and the cueing and kind of structuring the activity. There's still a lot of skills that need to be developed for both of these kids to be able to function with peers in sort of a typical play situation. But they're at the level now with their language and with their ability to kind of self-manage some of the behavior that they can be learning together in a natural context with some prompting and some support going on from those therapists. All right, so comprehensive behavioral interventions for young children. You can see that, that really the target and the outcome is addressing a variety of different skills with really young children intensively to build that base of skill to get them to the point that hopefully by the time they enter school or are age eligible to enter school, that they would be able to access the educational program without a lot of ongoing support. Targeted behavior intervention services, you might hear them called behavioral intervention services, BIS. The goals of these services include to assess the function of problematic behaviors through an evidence-based process and procedure called functional analysis assessment, which is really looking at the antecedent conditions that are a precursor for problematic behavior, the behavior itself, the consequences or outcome that behavior is then resulting in, and trying to determine what is the purpose or function that this behavior is serving for this individual. And then ultimately, what do they need to learn to do instead of the problematic behavior in order to be able to function more adaptively? So the goal is to reduce or eliminate those problematic behaviors and teach the individual replacement skills, more adaptive skills, and quite often those skills involve some kind of communication with other people to be able to get their needs and wants met in a more adaptive way. Just like with the comprehensive behavioral treatment, progress is monitored using objective data. So we're looking at not really so much qualitative changes, but more quantitative changes in behavior. Is the frequency, duration, and intensity of the problem behavior decreasing while the replacement skills that we're teaching, are they increasing? Are they generalizing? Are they being used more frequently? Now, according to the California Association for Behavior Analysis, in the guidelines that they published in 2011, which if you haven't read them, can be really, really helpful from the professional organization that most qualified autism service providers belong to. The guidelines really indicate who these services are appropriate for individuals who display behaviors that may threaten their health or safety, for individuals who engage in behavior that may be a barrier to their ability to remain in the least restrictive setting or that limit their ability to participate in family or community life, for individuals who have failed to acquire developmentally appropriate adaptive and functional skills that are fundamental to attaining social inclusion and increased independence. But here's something really important. In the California guidelines, behavioral intervention services can be effective for anyone, not just individuals on the autism spectrum. And these have been used for years for individuals with a myriad of different behavioral challenges, people with intellectual developmental disabilities, even smoking cessation, really the behavioral services, functional analysis assessment, behavior plan development really isn't autism specific, even though it is one of the services that can be paid for now through health insurance as a behavioral health service for people with autism. Who provides? So you'll notice one distinct difference here. There are 2 layers instead of 3. The qualified autism service provider, typically the one who accepts the referral, develops the treatment plan, evaluates, analyzes the functional analysis data in collaboration with the qualified autism service professional. And really this differs from comprehensive behavioral treatment for young children in that the role of the service providers is to assess, develop the plan, and then train and help people in that child or that person's natural environment know how to implement the plan. And change the variables that may be triggering the behavior by either adding something, changing something, or eliminating something that may be triggering the problematic behavior, teaching the replacement skills and reinforcing those skills, and learning to react or respond differently whenever the problematic behavior does happen. The location that behavioral intervention, targeted behavioral intervention services take place. Services can be provided in the home or in community settings where the behaviors are occurring. And I wanted to note too that schools do have an obligation to address these kinds of behaviors in a school setting for children who have behaviors that are interfering with their learning or the learning of others in a school context. There's actual ed code requirements that the school conducts a very similar type of assessment and develops a positive behavior support plan for the school setting as well. So there's some real overlap here in what the mandates of a school system are in what would be going on with this type of service through health insurance. The expected or intended outcome of targeted behavioral services, clearly we're looking for a reduction in problematic or interfering behaviors, but also an increase in the replacement or functional equivalent skill that we're trying to get the individual to do instead of the problematic behavior. So in the little example that you saw with the 2 boys, the one boy was screaming in order to protest or in order to indicate that he didn't want something to happen. Instead of screaming to indicate that he didn't want something to happen, we'd want to teach him a better, a different way to express that he didn't want something to happen. We're also looking for generalization and maintenance of the skills that are being taught into a variety of different contexts, and parent or care provider confidence in the newly acquired skills and strategies for addressing that problematic behavior. It does no good for someone to go in and, in essence, kind of fix the problem and then leave and have all of the conditions that set that initial behavior up to happen to all fall back into place. So really, in order for this to be successful in the long run, we really want to make sure that we've got some permanent sort of skill acquisition in place, not just for the targeted individual, but for the community that's supporting them so that their needs are being sustained. We don't have any video showing a behavior plan in action. It's kind of hard to get video and a release of somebody having like a tantrum. Normally, people don't really want to show you that, but we do have a couple of examples of data and what we would be looking for in a targeted behavioral intervention. So on the left side, which is the baseline condition, you'll see that in this particular example, the targeted behavior was off-task behavior, which of course in a comprehensive plan would be very well defined. What is off-task behavior? What exactly does it look like? And the baseline shows the percentage of intervals that particular description of behavior was occurring. And then the replacement behavior, pretty simply on-task behavior, which again would be defined. What does on-task look like? The line down the middle is when the intervention began, and then you can see that this is actually, we're having the desired effect. And this is what the data should look like when you've got the function and are teaching the appropriate replacement skill. We would see a reduction in the problematic behavior while we're seeing an increase in the new skill or newly acquired set of skills that we're teaching and reinforcing. In this condition, or this example with our friend Cody here, the percentage of transitions without challenging behavior. This is a pretty common circumstance in which an individual with autism might exhibit some problematic behavior when we're asking them to move from one situation or circumstance to another in transition. So this is looking at a specific condition, transitions, in which problematic behavior occurs. You can see on the left, there's the baseline. And then the intervention, we're seeing a significant percentage of transitions with no problematic behaviors. And then, of course, maintenance, if we remove the intensity, the frequency of the intervention conditions, is the behavior going to maintain? So they're looking here in this circumstance at maintenance of those newly acquired skills. Okay, so this would be a desirable set of data that we would hope to see if an effective plan is put in place and if the natural supports the providers are able to continue to support the new learning after the specialist is no longer providing the service.
So you can tell that we're talking about what it should look like. Doesn't always look like that, as we all know. And so I just wanted to walk you through the process under SB, what is it? 946, I can never remember it. I think the more you know as either family members or as physicians or other service professionals who are trying to help families understand this process and be good advocates, I think it's important. I think sometimes we assume somebody else is going to know this or do this. So first of all, you have to have a medical diagnosis to start the process for behavioral health services through your insurance. So you have to make a medical diagnosis. You need then a referral. It doesn't literally have to be a prescription or a statement of medical necessity, it turns out, but it does have to be a documented medical diagnosis. For behavioral health services can be made in managed care systems. It needs to be made through by the primary care provider. In other insurance systems, it can be made by the specialist who maybe made the diagnosis. So the patient then, it's the patient's responsibility or the family's responsibility to then call the customer service line or the mental health benefits number that's on the back of their medical card to then obtain a list of the covered providers on their insurance. So I've actually called through UC Davis. I said, so I'm giving this talk. I want to just make sure that I'm giving the right information. What would a family do if I just made this diagnosis? Is this what they would do? And I actually have to say it took me 4 calls to get the person who in our system is managing autism referrals. And once I got her, she was great. She knew exactly what the process was. So she said, you just flip over the card. Either they start with the customer service line, customer service provider, or the mental health benefits number, and they get the list, and then she actually thinks that the family gets to choose among all these providers. And we walked through a couple of examples of if you had this insurance through UC Davis, you would have these different providers. If you had this insurance, then depending on your plan, you would have these providers to choose from. So the patient then has the opportunity to have an assessment through the qualified autism service provider, and then have their insurance plan coordinator approve that service plan for those services. So there's the assessment, there's a treatment recommendation, and then the treatment plan is put in place. Seems fairly simple. We all know it's not really very simple, and I think that one of the issues that is very difficult for families, and one of the reasons why we really would like all of you who help families to understand the process is that I think families, just like with IEPs, need to know that they are very important in terms of making choices based on what the possibilities are for service, being able to ask questions, being able to be a part of the team, being able to understand what's the plan, what is it going to look like, where's it going to happen, and as Patty said, how are we going to make the transition from if it starts out with one-on-one in home, or if both parents are working, where is this going to be? How will I be involved as a parent? How will I learn how will I learn what you're doing so that when I'm at home I can be a part of this treatment plan as well? So I think these are all questions that parents really need to be asking. So then I think once this behavioral treatment plan is in place, there is then the requirement that the qualified autism service provider provides updates on, are we making progress? Every 6 months, there should be a reevaluation in terms of, are we making progress? Are we meeting our goals? Do we need to change the plan? Do we need to set new goals? These updates have to go to the insurance care coordinator. I can tell you as a licensed professional, I have never gotten an update for a treatment plan that I have not had to ask for. I can tell you they're not easy to get. Families rarely see them. They just go to the insurance and then it gets covered. So I think it's really important in terms of if we think back on the slide with the overlapping circles of the education plan, educational services, the regional center services, and then the medical and mental health services. I think this overlap in the middle is where we really need to be communicating so that we're all in the middle of those overlapping circles, and that we all have a sense of what is the treatment plan, what are the goals, are we making progress, does this seem to be working for the family, and how can we all work together to make sure that it's the right treatment plan, that we're making progress, and that the families are all understanding and being active partners. So I think this is something that we all wanted to emphasize here, is that really, if families should be expecting to be getting these periodic updates. They shouldn't just go to the insurance company and nobody else really sees them. And that we should be encouraging families to provide these updates to their primary care provider in the context of their medical home. They should be hopefully providing them also to some of the specialists that they're working with. Certainly want to share them with the regional center, as well as if they're in school with the educators and the people that they're working with at school. So we'd like to have primary care physicians then be able to take on a role to help families monitor progress, monitor the appropriateness of the goals, how's the family adapting to having this, particularly if it's an intensive early intervention or intensive program. And are there other things that need to be added to make this a more successful treatment program? It may be that there might be some medications. It may be that there's some other medical conditions that are interfering with the ability for the child to be in treatment and to be successful. The regional centers do require some updates to continue because if they're going to continue to provide support for co-pays and to help provide case management, obviously, they need to be reassured that this is an appropriate treatment plan and that the child is making progress. And we'd also like to think that the school would be involved in integrating the similar kinds of evidence-based practices that would be used in kind of the medical insurance-provided interventions so that there's consistency across context. So this is just a sample of, because primary care physicians have asked me, well, I don't know how to write a prescription for autism services, and I have a family that's asked me, and I don't really know what to say. Do I need to say how many hours? Do I need to say what? I don't know what to say. So this is just an example that I think is an appropriate one, both for a comprehensive behavioral health plan, just that Joe has a diagnosis of autism spectrum disorder and is being referred for assessment and development of a comprehensive behavioral treatment plan using evidence-based practices. So we would really like to encourage primary care physicians to make sure that they include evidence-based practices. Then another example is something that might be appropriate for developing a targeted behavioral treatment plan, and it might be, to work on aggression, to work on self-injurious behaviors. And I think a lot of times families come to physicians saying, I don't know what to do. Johnny's biting kids in the classroom, or banging his head against the wall, or, I cannot get him into the bathroom to work on toilet training, and so he can't go to school. So I think these are very appropriate concerns that families are bringing to primary care physicians. And this is kind of the expectation and sort of the avenue to help families get appropriate services. And then the other level, I think, of quality assurance that we need to make sure that we know about and that we need to encourage families to use if they need to is that the Department of Managed Healthcare and the California Department of Insurance also monitor all the insurance plans for whether they are being compliant with the legislation. They investigate complaints, and they actually can help families get what the legislation says that they are qualified to get. So I think really our major goal here was just to help all of you understand what this process should look like, how we hope that there's collaboration across these three overlapping systems that should be helping families and children on the autism spectrum, so that we can be better advocates and so that parents can be much smarter consumers of services and be better advocates for their children.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.